Welcome to Catalyst, a program about people, ideas, issues, and conversations around them.
Thank you for joining us today on Catalyst at the RETN station in Burlington, Vermont. I'm Betty Keller, and as part of a series called We're All in This Together, I'm recording shows about healthcare reform. Frequently they're specifically about Vermont, but today we're going to be talking about the broader topic of why doesn't healthcare seem to respond to free market principles to bring down our costs of healthcare when we have competition. And I'm very glad today to have with me Joshua Farley. Joshua is a professor at the University of Vermont and professor of economics. And today he'll be talking with us about why healthcare can't follow these free market principles. Thank you for being here.
Yeah, thanks very much, Betty. And I'd just like to preface this with the fact that I'm not a doctor, I'm not an expert in healthcare, but I have a pretty solid grasp of economics, so I'll be taking the perspective of an economist.
Thank you so much. Also with me today, I have Jonathan Bissett. Jonathan is a student at the University of Vermont, and he'll be helping me talk with Joshua and make sure that when he explains things, if we're not sure it'll be clear to the audience, we'll try to help make it clear so that you all will understand what we're talking about with these principles and healthcare not meeting them. So thank you. So could you talk with us first a little bit about, economics in the context, healthcare in the context of economics to begin with?
So economists, by definition, economics is the study of the allocation of scarce resources among alternative desirable ends, how we take what we have to get what we want. So the first question any economist has to ask is, what are the desirable ends? So in this case, what are the desirable ends from a public health system or a healthcare system? And just so I'm not, cherry picking desirable ends to make my arguments, I'd ask you two, as representatives of America, what would you think are the desirable ends of a public healthcare system or of a healthcare system?
One of the things I think is pretty important is not only being affordable, but also being reliable. It's important to be able to go to the doctor and know that you're going to get high quality care in a timely manner.
That's true.
Right, and that's related to the issue of access. You have to be able to get the care that you need, so that they have to have the resources be there, and you need to be able to access them just because they're sitting there. If you don't have the money for it, if you're not on the right insurance plan or whatever, or if you can't get transportation to it, access is very important. And having a system that can last in the long run, not just something that's working for right now, but if you're seeing down the long run, this is not working, we're going in the wrong direction, it's getting worse, it's getting more expensive, it's getting harder for people to access, then we need to have a more sustainable system.
Yeah. And certainly in our current system, we see the number of uninsured increasing and the costs increasing as a share of our income, and obviously it can't continue to increase faster than our income, or it's impossible to cover.
Right, and then when people say, oh, but we'll have this insurance mandate and there won't be as many uninsured people, there are huge issues around that still.
Yeah, and we definitely have to focus on those. And to begin with, I thought a good way to look at this, though, is to decide, what is it we really want from a healthcare system, and what measures might be of a good healthcare system. So I would say, for example, life expectancy is a good measure of the quality of your healthcare system. I mean, would you have any others to suggest?
Well, as a physician, I know that they frequently use, the infant mortality rate.
So infant mortality, and coincidentally, I happen to have some data on that. And so for a public healthcare system, you say, okay, we want to have, the simple measure might be years of healthy life. So is some good measure. But obviously we have to pay attention to the cost of the system. And obviously, people are very concerned about the rising costs. So what we want to look at is how to keep those costs down. But we have a healthcare system that's run by the corporate sector largely. And what's the goals of a corporation? What's the goals of a private sector business?
The primary goals of a business would be to make profits.
To make profit. And in fact, there's a legal obligation in this country for corporations to maximize their shareholder profit. So they're legally obliged. So as a nation, we want to reduce healthcare costs. So this is something we want to keep down. But if people remember the definition of profit, it's the total revenue, the total money you make, minus the total costs you pay out. So in this case, the expenditure of our nation on healthcare, that's the total revenue for the healthcare corporations. That's the revenue. The total cost, obviously, is what they pay. So if we have a healthcare system that's for profit, run by the private sector, the goal is to maximize revenue, which is our national expenditure on healthcare, and to minimize costs, which is what they pay out, which would essentially maximize their profits. So if we look at the first slide here, we can see that the first slide will show the total healthcare expenditures per capita. And this is from all the countries in the Organization of Economic Cooperation and Development, which largely speaking are the developed countries plus Mexico, Turkey, South Korea, a few others. And you obviously can't read the names on the bottom of the graph, but the one on the right-hand side in red is the per capita healthcare expenditures in the United States, 50% above any other country in the world.
But
So
50% above any other country doesn't look like it's 50% of.
it's a little bit shy of 50% above
50%
Norway.
above.
Yeah,
Right. It's not twice as much as 50%.
Yeah.
So it's like 150% of. Okay, I got it. Okay.
So it's not quite 1.5 times. The next highest is Norway, and at the bottom you see the poorest countries. You see Chile, Turkey, the poor countries that we certainly don't want to emulate. But this, from the perspective of the corporate sector, this is their total revenue. It's looking really good. But if we go to the next slide, it actually will show the doctor consultations per capita. So this is how often you get to see your doctor on average. And here suddenly we see the United States at the very bottom. We're one of the lowest countries. So we pay more for healthcare, and that's the revenue side, but the doctor consultations, from the perspective of the private sector, this is the cost side. This is what they want to minimize, and they seem to be doing an effective job at doing it. If we turn to the third slide, we see this is the number of hospital inpatient days per capita. How many days the average person has to spend in the hospital. And obviously you don't want to go to the hospital, but if you're sick, you want that kind of care. And again, we see that the United States, now we're comparing it to just the wealthier countries, so we can really see how we compare, but we're at the bottom.
So let's say which those countries are the US, the UK, Canada, France, Australia, and Switzerland we're comparing to. And of
Right.
those countries that we think of as being people we don't mind being compared to,
Yep.
it's not insulting to compare ourselves to those countries.
But you could throw in Germany, France, you could throw in most of the European nations, and you would see that we have the fewest days inpatient. So from the private sector's perspective, total revenue is maximized. We spend more than any other country. Total costs seem to be very much minimized. This is the goal of corporations, to maximize their profits, and they seem to be doing very well. And if we look at the next slide, it actually shows the profits from just drug company profits. And the red graphs show drug company profits over time as a percentage of their revenue. And the yellow lines at the bottom are the median profits for the Fortune 500 companies, so the richest 500 companies in America. And what we see is that drug companies do exceptionally well. So if our goal, the private sector healthcare is doing an amazingly good job at what it's supposed to be doing, is maximizing profits. But maybe we would think that it's really not the full-on goal. We talked earlier that better goals for a healthcare sector might be life expectancy. So where does the U.S. fall in terms of life expectancy relative to our peers or relative to the OECD, the Organization of Economic Cooperation and Development? And the next slide shows life expectancy in the U.S. relative to other countries. And what we see here is this, again, is just comparing us to the wealthier nations, and we're actually doing pretty poorly. If you do the whole 60 OECD countries, you see we're down in the lower quarter. Countries like Mexico and Chile and Turkey and not South Korea, they do better than us. Some countries do worse than us. Countries like Cuba and Costa Rica do better than us. So in terms of the desirable lens of life expectancy, we're not very good. Everybody also cares about children. We have babies. We really want to take good care of our babies. If we turn to the next slide, we can see infant mortality and how the U.S. compares on infant mortality relative to other countries. And here, we're way ahead. We have more than twice the infant mortality levels of some of our some of our peers, some of the other wealthy nations. So in terms of what we get from our healthcare system, we're not doing very well. People also care about mothers, of course. So if we look at the next slide, it shows maternal mortality. And again, we are, over almost 4 times the maternal mortality levels of Australia. This is women dying in labor. And it seems to me very unacceptable that we're so much worse off than all of the other wealthy nations. We can look at one more of these slides just to see what and this is the real data on, from objective data from government sources, and this compares the US. This is the additional years we could have lived. It's the potential years of life lost per 100 people for all causes. And again, the United States is at the bottom of the heap among the developed nations. So if, again, from a corporate perspective, we're doing a wonderful job, from providing public health, we're not doing a very good job. But economists, actually, we tend to talk about efficiency. How well do we do per dollar spent? So this is a very simplistic notion of efficiency, but you can take a look at, well, how much does it cost us as a nation? What's our per capita expenditures per year of life, per life expectancy? And if we go to the next slide, we see this is just very simply, it's the life expectancy per nation divided by their per capita healthcare expenditures is a measure of efficiency. This is not a measure of desirability. You don't want to be the most efficient because you can often do that by spending very little. But what we see is the United States is clearly the least efficient. You certainly don't want to be the least efficient. Again, we're the red and we're dramatically less efficient than other countries. So what we really want to understand is why is it that the free market, we're the most free market healthcare system of any of these nations we're looking at, and we're the least efficient, and we have the worst healthcare outcomes, but we have the best profit levels. And I would say there's a correlation between these, but what we have to ask is why is it that everybody is always pro-free market? Why do we want free markets to do everything? And as an economist, this is something I think about all the time, and free markets can be very, very amazing. And there's 2 functions they have that people really like. And it's all based on price. It's the price mechanism. And what they talk about is the allocation function of price. So prices, the industries that can create things of the most value can pay the most for raw materials. So the resources are allocated to the products of the highest value measured in monetary terms. And then those products, the rationing function of price determines who gets to consume those products. And we, rather than ration access with coupons, we ration access according to ability to pay, willingness and ability to pay. So the market will take those resources we produce and ration them to the individuals who value them the most as measured by their willingness to pay. So we maximize value on the production side and we maximize value on the consumption side, and that's a pretty impressive feat. But the question is our goal to maximize value, to maximize monetary value, which is somewhat akin to maximizing profits? And I think it's useful to illustrate this with something from the healthcare sector, and it's kind of interesting. I think it was Aventis developed a drug called eflornithine, and turns out it was one of their experimental drugs. They weren't quite sure what it was good for. Turns out it killed trypanosomes, which cause African sleeping sickness. Something like 70 million Africans are threatened by this disease. But when you look at the market, how much are those Africans willing to pay? Well, willingness to pay, it's your preferences weighted by your purchasing power, and these Africans have no purchasing power. They weren't able to pay much money for these products, so Aventis was very uninterested in producing it, because producing something for the destitute, you can't make a profit. Turns out that eflornithine has another function. It gets rid of unwanted facial hair in women. And here is a market, a very powerful market. So in the context of the allocation function of price, the allocation function of price will ensure that our scientists and our laboratories and our raw materials will go to the development of the highest value product, which is cosmetics for wealthy people. Hair removal formulas for wealthy women. So we'll do that instead of producing life-saving cures for diseases that affect the poor. The rationing function of price ensures that once we get that eflornithine, it's going to go to those who value it the most. And again, that is the hairy, wealthy women. So this is, many of us would think, well, geez, that's not what we want from a system, but that's the market working exactly as it's supposed to work. And any corporation that has a legal obligation to maximize returns for its shareholders had better be investing in cosmetics for rich people rather than life-saving cures for diseases for the poor. So, we have to therefore question whether markets do what they're supposed. They do what they're supposed to do well, but do we like what they're supposed to do?
Do they fit in with what we actually want?
Do they fit in with what we actually want? And another thing we have to ask about is, okay, so we can set aside this question. Let's say we do want to maximize monetary value. Accept that. But even then, there's certain things markets need to have for that to work. And one of these, for example, is you need a large number of buyers and sellers. And what they say is you have to be a price taker, not a price maker. You can't be able to set the price. The price has to be set through competition. So basically, if you have one firm and you have no choice but to go to that one firm, it's a price maker. They can charge you whatever they want. And I'd like to know, in the town you're in, how many choices of hospitals do you have to go to?
There's one.
There's one. And Jonathan?
We have a small health clinic, but that's it.
Yep, and here in Burlington, we basically have Fletcher Allen. And the fact is that the vast majority of people in the United States do not live in areas with a large enough concentration of people to have competition for healthcare. There's typically one firm, one hospital that provides it. And if you look at the next figure, it just shows a map of the United States that the black areas are those areas where there's a high enough population density to have a competitive number of hospitals. And in these areas, you could actually have hospitals in competition. In the other areas, we have what's called a natural monopoly. It doesn't make sense to have more than one. If we have two hospitals, we're going to have duplicated infrastructure we don't need. Two CAT scans, we don't need two. One can service all of Burlington. One MRI machine can service all of Burlington. So with a natural monopoly, what happens is if you did have competition, let's say we have a private sector hospital, it's the only hospital, it's allowed to earn monopoly profits. It's allowed to charge as much as it wants. It's a price maker, and it charges the prices that maximize profits. It might make a lot of profit. And that might lead another firm to come and say, wow, they're making so much profit, we're going to build another hospital there. And we're going to build that other hospital, and we're going to put in an MRI machine and a CAT scan machine because we've got to compete with that hospital. But when we do this, we've just duplicated the costs. And the first hospital actually had enough capacity to meet everybody's needs. Now we have competition. Now we have two hospitals, but we've doubled the cost, which makes it impossible for those hospitals to lower the price.
Because they have this infrastructure that they need to have there. So when they're setting, they're price makers, but when they're filling out their price, they have to figure out what are the costs, what are our expenses, and we have to cover that plus make our profit.
They have to cover their expenses plus make a profit. And in this case, as soon as you have more competition, you're seeing more expensive healthcare system. And if you look at the next slide, I simply took the figures from the OECD on the number of MRIs, magnetic resonance imaging. United States, world leader. We have more of these machines than anybody. And the reason is we have a so-called free market healthcare sector, which means that when two hospitals are in a town, they compete to get patients, and they're going to have duplicate twice as many MRIs as they might need in a town like Burlington, which is why we have more MRIs than any other country in the world and more expensive healthcare system. Competition in healthcare leads to higher prices. And it's because of the physical characteristics of hospitals and CAT scans and MRIs. You don't need that many to service the needs of your population. It's the same idea behind it would be silly to have two reservoirs and two main water pipelines. Replicating infrastructure is silly. That would raise the prices of water. If we duplicated our sewage infrastructure, it would create competition but raise the price of sewage. That's why we don't do that for water and sewage. So another thing to think about is how does insurance companies affect the number of sellers? So I have Blue Cross, Blue Shield, considered very good insurance. And I broke my arm pretty badly this summer, and I have the big stitches to show for it. And when I went to the doctor, well, I had to go to a doctor that was covered by my provider. So there's a bunch of orthopedic surgeons here in Burlington, but only a subset of them is covered by Blue Cross Blue Shield. So immediately, the number of providers of healthcare for me was limited because I have Blue Cross Blue Shield. Unfortunately, all of them but one were on vacation, which meant I had a 9-day wait with my bone ends grating together, a badly broken bone, dislocated wrist, just flopping around. They put me in a splint in the emergency room. Then I had to wait 9 days for surgery.
Right. So how does that sound to you?
That sounds pretty brutal.
So, and he lives in America. And what do people usually think about American healthcare?
I'd say the common conception is that because we're America, we have, of course, the best and fastest healthcare there is, and the best and fastest everything there is.
Yeah, and have you heard things about waiting periods in other countries? What's the general stuff you've heard?
I haven't heard too much about specific other countries, the amount that people wait. I have heard that there are countries where you can move pretty quickly through the waiting process. But
Yeah, okay. A common misconception that you hear is that, the waiting lines are so horrible in England and Canada, because those are the two that we often compare to because we know more about those. Canada is so close, and England, they speak the same language, so we can know more about what they're doing. And if, I was just starting to say, so we hear about these waiting periods in these other countries, but here he lives in America. He has Blue Cross Blue Shield insurance, and he had a 9-day wait because he had to wait for the provider who was on his list.
Yeah. So I had to wait, and I have to say, I think the medical care I got was excellent. I have no basis for comparing. It's not like I've ever broken a bone before, but I thought my doctor was top notch. Part of the reason I had to wait, so every time I went to see the doctor, I also had to wait a long time, and that's because she is top notch. She makes sure she will squeeze in her patients, and she will meet people. But I actually injured my arm again doing something foolish, moving a table, and then when I called to make an appointment, they said, don't even bother, it would be weeks. So I had to go to the emergency room, which is a far more expensive form of treatment, although I am told that my doctor would have squeezed me in. But the point is, I didn't get a choice of doctor, although I think I ended up with a good one, and I had to wait a long time. And so the free market, and that's because of having insurance companies that limit my access.
And the insurance company was trying to get more business from having different companies sign up, but to keep their prices down, they try to do contracts with the providers.
Yep.
So if they do contracts with the providers to try to get a good deal from the provider, the doctor or the hospital or whatever, then that means they limit how many providers you can see.
Yep.
So the competition is actually creating the lack of access.
Right. So in this case, it's the insurance companies that create the lack of access, and through the free market mechanism, supposedly.
Okay. Thank you.
Another thing for free markets to work, theoretically, is you have to have no entry or exit barriers, meaning anybody who wants can, if they see that doctors are making, orthopedic surgeons, for example, if they see they're making a lot of profit, then they would be free to enter that market. So Jonathan here could say, I'm going to be an orthopedic surgeon. And but there would be obstacles to you doing that. We do have barriers. You have to get a medical degree and pass your medical boards. Personally, I'm comfortable with that. The idea about a free market is Jonathan could declare himself an orthopedic surgeon, and if he didn't have high patient satisfaction because he doesn't know what the heck he's doing, then they wouldn't go back to him and the market would select away. I think it's better to have rigorous barriers to entry, but rigorous barriers to entry do prevent markets from functioning effectively. Another barrier to entry, of course, is drug companies. When drug companies develop a new drug, they get a patent on that, meaning no competition allowed, meaning you have a monopoly on that drug. Very frequently, the drugs are developed with public funding through the NIH or through the Center for Disease Control, and yet we still turn the profits over and the monopoly profits over to the private sector. So that's another problem. Another big prerequisite for markets to work, they say, is perfect information. You really have to know what your choices are. And you can look at this on the demand side as the consumer. I would really have to know what my choices are. To be honest, I've broken my arm once. I have no idea how good the orthopedic surgeons are. I wouldn't have been able to make any kind of qualified choice. And I don't know if you have enough, and you're a doctor, if you had something outside of your specialty, do even you know enough to make a qualified choice?
Well, the issue, though, is not just would I know enough to make a qualified choice, but say I was traveling with my family and one of my family members broke their arm in this other place, I wouldn't know those providers. Even if I know what features to look for, I don't know how good those doctors are at those features.
So this is a huge thing, is that unless you're an MD, and even if you are an MD, you might not know enough about how to choose an appropriate doctor. You can theoretically go get a second opinion, but when I was laying there with my arm split in two, to go to another doctor, make another appointment.
If only one was on your insurance plan.
And only one was on my insurance plan, but even if I could have shopped around, even if it's just not very effective to shop, or it doesn't make much sense to shop around. And very often your community, of course, doesn't have enough people to support more than one doctor anyway. Another issue, though, is on the...
Well, let's talk about that a little bit
yeah.
longer then. So you're laying there and you have to make a choice about a provider. If you're trying to choose like which deodorant or toothpaste to get, you see all the choices in front of you, you can pick one out. In this case, to get your second opinion, you're having to pay already for the second opinion.
And wait a long time to get it.
Right. So you're just building up more waste and waste into the system.
Yeah.
Okay, thank you.
And I personally am not qualified to judge. I'm the son of doctors, and my brother's a doctor, and I probably have as much medical knowledge as more than most laymen. But even I certainly couldn't be qualified. But on the other side, there's the supply side too. So the insurance companies that sell us insurance, they don't know, they don't know everything about our health that we might. They don't know what our habits are. They don't know what we do. So they have to assess how much we might cost them, but that's very difficult for them to do as well. So they don't really know what price to charge us. For an insurance company, it's a very small percentage of people that actually account for most medical costs. In fact, the next slide shows the costs, how much each decile, each 10% of the population accounts for costs and these are insured people. So these are the folks who have insurance. And what you see is over 60% of the costs are the result of 10% of the people. I think it goes down to the top 1% responsible for over 25% of the costs. The top 20% is responsible for nearly 80%. But if an insurance company wants to maximize profits, the way they're going to maximize profits is to be very careful not to give insurance to one of those people who might be very sick. So at all costs, you don't want to insure that 1% of the people who accounts for 28% of medical costs. So what the insurance companies do is they spend a huge amount of money making sure they can find out what your health record is, so they know whether or not they will be making a profit by insuring you, which is why they deny you can't get coverage if you have some kind of pre-existing condition. So I have a nephew who's has cerebral palsy, and great guy, highly functioning, everything else. But my brother had to stay in the corporate sector job he had because then he could get insurance through his job for his son. And he's an entrepreneur. The day his son got a scholarship to Houston University that paid for all his costs in an entrepreneurship program, my brother could go out and start his own business. And he started it in the recessions, hired 10 people, got a business going. He couldn't do that. He couldn't use his entrepreneurial abilities when he depended on another corporation for his healthcare costs. And now, one of his biggest obstacles, he's providing health insurance for 10 people, and that's an incredible expense for him that businesses in other countries simply don't face. They say that now GM spends more on health insurance than it does on steel for each of its cars. So that's a big disadvantage GM is operating compared to other countries, which all the competing nations all have public sector healthcare. Mm-hmm. So what we see then, if you look at the next slide, you see that we deny care. The way you maximize your profit by denying care, you spend a lot of money to figure out who it is that you don't want to provide care for. And this slide just shows the increase in administrative personnel versus physicians in our healthcare system. So from 1970 to 2009, we saw something like for me it looks like 100%, 200% increase in physicians, and a nearly over 3,000% increase in administrators. Because you need those administrators to be reviewing everybody's healthcare records and making sure they don't hire they don't accidentally insure the sick, and that they don't insure anybody with a pre-existing condition. So we see this skyrocketing in administrative costs because of our public healthcare, because of our private sector healthcare system, and it's very problematic. The next slide actually shows the number of people in America who die every year because they're uninsured. So it's 45,000 adult deaths. These are people who can't afford insurance, can't go to the doctor, and very often we have decided as a nation that if you show up at the doors of a hospital, deathly ill, you will be treated. But these chronically ill people who would have diseases that should be controlled, diabetes, heart disease, hypertension, you should see them regularly to keep them from having to show up at the hospital door. But those are people who they can't go until it's too late and they die. So we see that we have more people dying because of that. Sad fact is, though, that even among those who do have health insurance, medical costs can be incredibly high. And the next slide shows that the bankruptcies associated with health emergencies. So this is when you have a medical condition that drives you into bankruptcy. 60% of the people who experienced that had private sector health insurance. Problem is, I talked about imperfect information. I think my insurance plan probably runs 250 pages. I didn't read it. I didn't read all the fine print. If I'd wanted to make an informed choice, of course, I would have had to read 6 different insurance plans and choose the best one, which they change every year, so that I'd have to and read all the fine print. But people don't read the fine print. They don't realize that when you really do get sick, your insurance company might not cover you, and we end up with these bankruptcies caused by
Right, now if we can look at that slide again, so on that, it shows that about 60% had insurance, but they went bankrupt anyway.
Yep.
And sometimes that's because they had their deductible first,
Yep.
and then they had to pay their copay after that, and that really adds up. And for some of those people, it may be that whatever the particular item was, the insurance may say, oh, we'll cover you in general, but we don't want to pay for that.
Yep.
So that doesn't get covered. You see that of all those medically bankrupt people, only 22% had no insurance. So if you talk about people who were irresponsible, they didn't buy their insurance, but only 22%, how about all these other people? People who are on Medicare and Medicaid and going to the VA military, you'll notice the VA has the lowest.
Yeah.
But people going who had Medicare and Medicaid still had bankruptcy because of issues around deductibles and copays and paying for the medication and stuff. And every state's different, so these are probably national things, I think, that might not be as bad in the Vermont numbers. Thank you.
Actually, I think Vermont is a lot better on a lot of these issues. We're not. So what we see though is there's a lot of reasons why markets really fail to provide medical care effectively, and there's a couple more I'd like to talk about. One thing about medicine one thing about a market's only work if you can keep somebody from using the service unless they pay. So we could have healthcare for a market and healthcare to work. We would have to be willing to say, if you're not paying for it, you're going to die. But we decided the Hippocratic Oath does not allow doctors to do that. Hospitals do not allow that to happen. If somebody shows up at death's door, the hospital will take them in, will cover the costs, so what we call this in economic jargon, it's non-excludable. You are going to get some health care no matter what. When that's the circumstance, the goal is to figure out how we can provide that the cheapest way possible. So that should be the goal of our healthcare system. That's one big issue for healthcare. If you can't exclude somebody from using it, the market doesn't work. Another big issue in economics is this idea, it's called externalities. But what it means is if my use of the healthcare system has any impact on other people, then the market might not work as well either. So when I was a kid, I used to travel around a lot and didn't have money, so I'd be sleeping on the floor of second-class Mexican trains and ended up coming into contact with tuberculosis. Probably, I didn't really contract it, but I've been exposed to it, so I test positive for it. And back then, we had a system that recognized that tuberculosis is a highly contagious disease. Everybody is better off if I'm treated. I teach about 300 students a year, a little more than that actually, and I actually got public sector health coverage, covered my 6-month treatment for this, and that means my 350 students a year are not exposed to my tuberculosis. Ronald Reagan, in his infinite wisdom, decided that we need free markets, because free markets are always the best, and we shouldn't be paying these costs to treat tuberculosis. Most people who get tuberculosis tend to be, not to use stereotypes, but it's often poorer people, often people who are exposed to difficult conditions, often drug addicts, and you do get a lot of these people who get tuberculosis. And we used to have a system where public sector doctors would go out and insist they take their medicine. They would follow through and make sure. Ronald Reagan thought that was a waste of money, stopped doing that. So what we got was people sporadically taking their medicine, which led to the evolution of multiple drug-resistant tuberculosis. And now we have all sorts of, we have tuberculosis that we can barely treat. And there's all sorts of contagious diseases. In the human history, the largest source of death, besides old age, has been contagious disease. The flu epidemics, the plague epidemics. And that means if some people don't treat themselves for that, one thing is other people will be a lot more susceptible. If people didn't get polio vaccines, we would have a lot more polio. Fortunately, Jonas Salk refused to patent the vaccine to make it accessible to all. And the other thing is, if some people don't get treatment, and I do get treatment, but those who don't get treatment, we have a disease now that can thrive and evolve. And it's like the flu evolves every year. And other diseases evolve a bit more slowly, but if some people don't get treated, we can get more evolution of these potentially lethal diseases that could have catastrophic impacts. And everybody benefits when people take their vaccines. Everybody benefits when people get treated for contagious diseases. And if you use cost to ration access to the healthcare system, many people won't get treated, and we're going to be guaranteed more pandemics, more diseases. So again, it's another reason the market simply doesn't work.
So if you have more people get those diseases, then there are more people who will be on the list of people who should be buying those drugs.
Yeah.
So that actually benefits the pharmaceutical companies. They continue to have more business. You don't actually want to cure something and wipe it out, because then you don't have anybody else to keep on selling it to.
Yeah.
So that's not, their motive is not to get rid of the disease and to stop people from having the disease. Their motive is to make more profit.
Yeah. And this is actually one of the things that's the irony of like something like a vaccine. So let's say we get a very serious avian flu or a swine flu coming through, and we develop the vaccine. The private sector wants to maximize profits, and they do that by charging a high price. But to maximize the public benefits, and so often it costs a lot to develop the vaccine, but then pennies to provide to somebody else. If we provided it to everybody, for pennies, we would vaccinate the whole population. The total value to society is dramatically increased when everybody uses this. It's like we got enough people to take vaccines against smallpox. We eliminated one of the worst diseases on the planet. Only not by making the vaccine free, but by aggressively spending money to ensure people got it. And so the values of many medicines are maximized essentially by paying people to take them or covering all the costs involved in them taking them. Mm-hmm. And whereas the market will try to restrict access to maximize their profits, the values to society are highest when the price is zero. And of course, the market would never provide it at the price of zero. So this is one of the paradoxes of markets in healthcare, is there's no incentive for markets to provide it at the price that does the greatest benefit to society. Mm-hmm. Those are some of the issues. There's, again, what I think about often as an economist is how do we minimize the cost to society? How do we have the lowest possible cost to society? And, and as a doctor, so what do you find to be more cost effective, preventative care or curative care? Keeping people from getting sick or spending money on them when they become very desperately ill?
Right. If you can treat them earlier, then it costs far less. Or if you can change their lifestyle, it can cost far less. Now, some people say, "Oh, well, then if everybody took better care of themselves, we wouldn't have to spend so much on healthcare." But there are some things that will happen no matter what. So you can't blame the patient that they got sick because they didn't do all the preventive things right or something.
Yeah. And so they've done studies to show that for every dollar you spend on prenatal care, you save $3.40 in postnatal care. So really, really efficient. Mm-hmm. Problem with that private health insurance is that people on average, your health insurance is tied to your job, and even within the job you can switch fairly easily, or sometimes you can anyway, sometimes you can't. But people on average end up staying with a healthcare provider for less than 2 years, an insurance company. So an insurance company could theoretically lower cost to society by paying for preventative care. But the chances are that person you paid for preventative care would switch to another provider would profit from the first insurer's preventative care payments. So the private sector has very little incentive to do preventative care. And you talked about these lifestyle choices. Some people say, well, people who eat too much, they shouldn't get free health care. Well, it's interesting that just today, Medicare, I don't know if it was Medicare or Medicaid or both, has announced that they will now pay for obesity prevention. So preventative care for obesity, one of these lifestyle choices, because that's going to keep the total cost down. That's going to reduce costs for society.
I'm just wondering, did you follow that quickly enough when he was talking about why insurance companies don't have a motivation to have you get your preventive care? Did you follow that well enough to restate it for the audience, or should one of us make sure the audience gets it?
Why they'd rather do the care after someone gets sick than before they get sick?
Actually, they don't want to do the care after they get sick either. They want to stall it out and have a different insurance company pay for it down the road. They want to just not provide the care if they can avoid it. I'll just restate it so that if you're currently, say, on Blue Cross Blue Shield and your employer checks out the contracts and November comes and you reapply, you probably don't know this yet, but every year your HR, the human resources person for a business, will check to see what contracts they should do on healthcare because it costs so much for businesses. So they might switch. So there have been years where, my husband's company, changed 1 year, 2 years later they changed, 1 year later they changed again. So if a company can't rely on your loyalty and they may not have you when you get sicker, then they have a high motivation to not bother treating the preventive. Now, if there's a big enough motivation, if the company says you guys need preventive health care, we'll look for that in the policies when we are evaluating. We consider that important for our health care for our employees. So we will make sure when we get a contract that it does have that. But it's not in the interest of the insurance company to provide for that unless their competition means that that's what they have to provide to make the deal, to make the sale of their insurance plan.
Do you know who your insurance company is right now?
I believe it's Catamount Care.
Oh, Catamount Care, okay. So is that...
Is that as a student or through your family?
I think it's a Vermont government thing.
Yeah, well, that's different.
Yeah, not exactly sure. But I was going to ask a question about with people such as obesity and stuff like that, the graph you threw up earlier, or the chart you threw up earlier about life expectancy, whether or not that would more reflect on the lifestyle choices that many Americans make versus whether or not that's an accurate depiction of the quality of our healthcare. So I think that would be an argument that would be easy to make against that as a point.
That's certainly a relevant issue, and it is true that America is the most obese nation on the planet. I believe we smoke quite a bit less than Europeans. So the Europeans are a bit more slender, smoke a bit more. Not quite sure how that balances out. It does remind me, though, of a very interesting discussion I saw in the newspaper between two economists, I believe Gregory Mankiw and, I forget the other name, but two columnists in the New York Times, and they were talking about whether or not we should have taxes on foods that make you fat to reduce obesity. So essentially people would be paying for their additional health care costs. And Mankiw is arguing that no, we shouldn't tax those people because they die earlier and that reduces their overall healthcare costs. They don't impose higher healthcare costs. And the other economists are saying, no, they don't die enough earlier to reduce overall healthcare costs, so we should tax them. Whereas I would think just having them live longer might be a desirable end of itself. But you don't just look at things in terms of what's cheapest. There are other ends than efficiency. But I just thought that was an interesting
Argument. Oh my gosh.
There was another question that I was going to ask earlier when you were talking about choice of physicians for your broken arm and that you went to Fletcher Allen and there are 8 doctors, but all of them were on vacation but one, and then you still had to wait. Were you able, through your insurance plan, to say go to the hospital in Montpelier or in Morrisville or any of the other?
To be honest, I didn't give it a huge amount of. When I went to the emergency room, they treated my arm. They said, go to this doctor. Didn't ask me if I wanted to go to this doctor. They set the appointment up for me. I went to that doctor, and she said, well, it's going to be. So it took me 2 days to see her. Then it was going to be another week before I'd get surgery. And at that point, I was thinking, geez, 9 days. I'd like to be healing for those 9 days rather than So I did then call, and I did learn that, and I'm not sure how many were there. I think 2 were on vacation. She was there, and I did try to find out about other providers. And I did find another doctor I could have gone to see, and I called up, and again, it would have been a very long wait. They said there's no way we could squeeze you in less than a week. So, so I gave it up kind of there. I didn't, and it's partly it's a huge hassle to try to figure it out. I had to make all these phone calls. I was playing phone tag all day, and it was, it's just difficult to do. But a good question. So,
Now, did we talk, when I spoke with you before the show, we were talking about exclusivity. Can you explain what exclusivity is and then tell us if we already talked about that, or?
Excludability, like.
Oh, okay.
So the basic idea here is that markets only work if you only get something if you pay for it. And I was pointing out that our medical system, one thing is that we will treat people ultimately, no matter what, if they go to the emergency room because they're dying. It's an extremely expensive way to provide medical care.
Right.
But because they do have that option, that means the market would be less efficient anyway. And another thing about this excludability is if I get treatment, the benefits go to everybody. So again, that example where I was treated for tuberculosis means that you two are not in danger. So the benefits of my treatment go to everybody, not just to the individual.
Okay, that's what I was thinking of. So for infectious disease, if other people get treated too, then that reduces your risk, other people's risk of getting infectious disease. For high blood pressure, if you get treated for your high blood pressure, can you figure out how you and I would benefit from him getting his high blood pressure treated now? Because it's a long-term chronic problem.
Only in the benefit that he would maybe not die due to high blood pressure or have any problems with that, that he'd still be around to contribute to society in whatever way he does.
So he'll continue to keep on working, and then he'll probably retire at whatever age. But after he turns 65, high blood pressure probably won't kill him before 65, maybe if he has other risk factors and develops a cardiac problem. But he'll probably live to 65, and then after 65, he's going to have worse health problems because of the long-term chronic effects of the high blood pressure. And then you and I are paying because he'll be on Medicare by then. So the insurance doesn't have to deal with that long-term complication. They put out that, but it benefits it, and so if he had a high deductible and didn't get the care, the insurance company didn't have to pay out on it at all because he didn't bother going because he didn't want to pay the deductible first. But you and I then will pay the higher cost of him having worse disease when he turns 65 and is on Medicare, and we're paying for that out of those funds.
The other thing is that insurance companies, they very carefully try not to insure people might get sick. I have another niece who's got asthma, and so she's almost impossible to insure. But when the insurance companies say, we're not going to cover those people, and as a society, we've decided we're not going to just let those people die, that means the insurance companies choose the healthiest people and leave the sickest people for the public sector to take care of with all our tax dollars.
So the sickest people will be on Medicare because they're older and they've been around long enough to accumulate a lot of disease. People who are on Medicaid because they might be so sick they got cancer, they couldn't keep on working, and then they lost their job and they lost their insurance and they're on Medicaid. Or they might have other issues that get in the way of them working, so they're on Medicaid. And then there are public programs that help out people who were not insurable. They could not get insurance through their work because they were denied. And so there are things like Catamount Health and VHAP and each state will have its own programs trying to cover those people who have a gap. And sometimes those programs, because of budget cuts, because of the economy, will be cut, and then people can't pay their premiums, and then they become uninsured again.
Yeah. Although one thing that's kind of ironic, and I should have put this slide up and I didn't do it, but the only place where American healthcare system does well compared to European countries and other wealthy nations, life expectancy after 65. So if you've made it to 65, we live as long as Europeans. And is that coincidence that at 65 is when we become part of a public healthcare system?
Yeah. Now, did you have other slides we wanted to talk about?
No, I don't have any other slides, actually.
Okay, great.
I just wanted to say one thing, though, that if we do want to really reduce our healthcare costs, the way insurance companies work is you pool risk, and that minimizes essentially you pool risk, and it allows you to offer the insurance at the lowest possible price because you balance people's risk. So what you really want is a single health insurance company, and that's known as single-payer medicine, which is single-payer healthcare, which is what Canada has. It's I think Taiwan has that. England has some version of that. Vermont is talking about moving that way. It looks like we might. But this, just from pure economics, this is the most efficient form of healthcare insurance. And when you only have an insurance company, right now, if you go to Fletcher Allen, they have a whole, bunch of staff that are just dedicated to figuring out the administrative details of different health insurance companies. So we replicate these costs everywhere. Canada, they don't have anybody doing that. We just have one health insurance company, one form. It's all taken care of. So that dramatically reduces the costs. You get rid of all your profits, so that lowers the cost of medicine.
Each insurance company may say, oh, we don't have that high of profits. But the reality is they have lots of expenses that they wouldn't have if they weren't having to pay so many people to try to deny your care, to try to figure out who not to cover and all those sorts of things. All those, and
Absolutely.
Marketing, to pay somebody to go from employer to employer trying to get a new contract every year. And the other, in the other companies, pharmaceuticals and stuff, the marketing they do, to the consumer to try to get you to tell your doctor which drug you want because you saw it on TV.
Yeah.
So all those expenses they're not counted as a profit when companies say, oh, we don't make that much profit, but those are their expenses that we're paying for.
Yeah. And I mentioned earlier that, we patents on medicines are a form of monopoly. So we give these monopoly rights to pharmaceutical companies, and that allows them to charge astronomical prices. But when you have a single healthcare provider or a single health insurance company like they have in Canada, that allows, and you have a single buyer of all those medicines, and they are on par. They can, negotiate fair prices. So Canadians pay half as much for medicines as we do because they use their monopsony, single buyer power, to counteract the monopoly, the single seller power of the pharmaceutical companies. So there's just all these ways you can really reduce your costs. And as you pointed out, I think this is one of the most important things. Any money a health insurance company spends trying to avoid providing care for somebody is just purely wasted money from the perspective of of having a healthy nation.
So in a country that has a single payer, has a single plan, they don't pay people to try to deny your care, but they do pay people to help you figure out the best care because they want to make you as healthy as possible so that you're out there paying your taxes because you're able to be well and working, and they want you to be well and not have more expensive care later on. So there's that motivation when it's a public plan that they will still have those administrative costs, but that's a different notion from just trying to deny your care. Now, you, I think, had some questions about the free market.
Yeah, well, there is one of the arguments I've heard against the single payer idea is that, so yes, we'll be able to bring down the prices of drugs, but then that will also de-incentivize people, and also that it'll bring down doctors' salaries as well. That'll de-incentivize people to go into medical research and medical professions. And then because is the U.S. currently and then I was also wondering if we are currently the leading producer in pharmaceutical production.
Yeah, I don't know the answer about pharmaceutical production. I do know, there's no question that in the U.S. our doctors are better paid. I believe it's orthopedic surgeons are the highest paid relative to other countries. But doctors, they don't make out too poorly. So it's not the first class whose income, and I come from a family of doctors. My brother's a doctor, my sister-in-law's a doctor. It's not, nothing. I love doctors, but I think they make enough that if it means a more efficient healthcare system. But the point is, we could actually choose to pay doctors as much as we do now. It would be the choice of the single payer, and still save a lot of money. But
so you would want to make sure that you pay them enough so that they will go into the field. And maybe a big incentive would be to actually have the medical schools be free so that they aren't having to worry about paying back the loans afterwards. Some countries do that way. But in a public plan like that, everybody is on the plan. And if you, as the politician, are on the plan, and you as the administrator helping set the fees that you're going to pay them are on the plan, you personally have the motivation that you're on the same plan, you want to have access to doctors, and if you're a politician, you want to be voted back in, so you want your constituents happy. So if they can't get to their doctors, they're going to vote you out. So there is the motivation with a public plan that if everybody if you have a special plan for the politicians and the wealthy people, that will be different. Okay, but as long as we're all on one plan and there's motivation by everybody to make it be the best system possible, that's the drive of why it should work anyway, even if you don't have that competition.
And I think the important thing to look at is, as you saw, doctors, accessibility of the amount we visit our doctors is less than almost all other nations. Our healthcare outcomes are worse. So perhaps we do end up with more doctors, but for whatever reason, other countries end up with better healthcare outcomes. And I think that ultimately has to be the goal. And I don't see a shortage of doctors in these other countries. What they tend to get sometimes is you don't get this huge rewards for being a specialist. You might get more family doctors, more general practitioners, which actually is what we need to keep our healthcare costs down in this country too. It was a very good question, I think. And in terms of the investments we have in the pharmaceutical sector, I do believe, I know we have very, very high investments in pharmaceuticals and huge research and development costs. But pharmaceutical companies actually spend more advertising their medicines than they do on research and development. And so as far as I'm concerned, that's kind of just a waste of money, especially when you have all these drugs that are quite similar and these generics that work just as effectively. But and they've done a lot of studies to show that these drug companies, when they give money to doctors for research or for meetings, those doctors are far more likely to prescribe their more expensive drugs. And it's unintentional.
There is more we could talk about why the free market doesn't work, but I want to thank you for your time and wrap things up for our audience here. Thank you so much for coming, Jonathan, and Joshua for presenting. And thank you for joining us today in We're All in This Together, being produced as part of Catalyst here in Burlington, Vermont today. And after the show, there will be some websites listed that you can find out more information, and hope that you will become involved in trying, in wherever you live, to try to make the healthcare be the best we can for taking care of each other. Thank you.